Hello, everyone. You're welcome to another episode of Early Intervention Matters podcast series, and we're happy to have you back here again. This is Neurodevelopmental focused podcast, but centered around families and the public being aware of neurodevelopmental conditions. And we hope that the discussions that we've been having over the months have been very useful for you. So today we're very privileged to have a very senior pediatrician who is also highly experienced over the years. I'll introduce her and tell you a bit more about her. We're very lucky today to have Dr. Ngozi Oluonye, a consultant pediatrician based at Great Ormond Street Hospital and Moorfield Children's Eye Hospital. So we'll let her say a quick hello, and then I'll talk a bit more about Dr. Ngozi.
Hello, Ngozi. Hi, thank you, Yang, for having me on this podcast. We've spoken about this for a little while and we've managed to do it today. So I've seen and I've heard some of the wonderful work you've been doing over the last few weeks and months, and I know how busy you are as well. I'm looking forward to having this conversation with you.
Thank you, Dr. Ngozi. So just a bit about Dr. Oluonye. I'll call her Ngozi because I've known her for so many years. Ngozi and I go way back in medical school when we met at a very lovely medical school, University College Hospital, Ibadan, one of the premier university in Nigeria. We both studied there, graduated medicine, and then went on for further studies. I was extremely happy when I reconnected with Dr. Ngozi back in the UK when we both happened to be doing the same course at the University College London. She had done the course just before I started. So it was lovely to reconnect with her and also know that we had gone in the same line of specialties. We both became very interested in neurodisability and neurodevelopmental disorders, and both worked in Great Ormond Street. I left after that to my current post, and Ngozi was away as well. Worked in Luton and Dunstable Hospital before coming back to Great Ormond Street. So Ngozi has been a well-rounded neurodisability pediatrician involved in clinical pediatrics, assessing lots of children with neurodevelopmental disorders, but also academic work. Her interest has spanned various conditions, including autism, ADHD, developmental difficulties, intellectual disability, but she's also expanded her interest over the years to become interested in functional vision impairment and the development of children with visual impairment. We're really hoping to have her back soon to talk about vision because she's doing an amazing work and she's part of groundbreaking research in the country on vision, and there's been some amazing things, some of which have been featured already on the national news. So, Ngozi is a member of various associations, but one important thing related to the topic of today is that she's not only been a clinician, but she's actually taught the administration of one of the one of them called Griffith's Developmental and Mental Skills. So she's been a tutor for that course. She's taught people how to assess children's development. And she's also been a trustee in the Association for Research in Children and Infant Development, ARICD, where many pediatricians involved in neurodevelopmental assessments are part of. So we're very fortunate to have her. She's taken part in so many studies. She's co-authored chapters. She's presented at international and national conferences. And another interesting thing about Dr. Ngozi is she's got many parts. She plays the piano. She's got a great voice. She enjoys singing, spending time with her family, and going to the gym, keeping healthy, and doing jigsaw puzzles in her spare time. Dr. Ngozi, thank you. Thank you so much for joining us and such a rich CV and experience. Great. So today we're talking about something that's very important, and I think something that needs clarity for families because many times they hear these terminologies, they see clinicians, people mention things, but they're not sure. There's sometimes confusion about what constitutes developmental delay. So I thought that this was a good starting point to talk about what developmental delay means and what our families should know. When do we say a child is delayed? How can families spot the early signs? Should they do in this world today of difficulties with accessing services? We know that in the UK, we were talking about this recently, the surveillance and the monitoring that used to happen for children very closely no longer exists. We've just had the budget in the UK where lots of things are being cut. There's a lot of changes going on, and it's so easy for some children to be missed when systems are being destabilized. So we would like to talk about what parents can do and how they can support children, where they can seek for help. But also, we do know we have an international audience. We know our podcast is listened to in various parts of the world. So this information will also be helpful for our audience that's listening from other parts of the world. So we're looking forward to having a very interesting conversation, but one that will be informative as well.
Thank you.
But when we say a child has developmental delay, what does that actually mean for the child?
Okay, thank you, AI. It's a term that parents use, and it's been around for many decades, and we use that term developmental delay to describe what may be expected skills that should have emerged at certain times of a child's life. So when we think about the term developmental delay, kind of like to call it a descriptor because then you can expand on those descriptions. But what it does, if a family are told or a parent is told that their child has got developmental delay, what that means for that child is that now there needs to be ongoing monitoring. There needs to be some specific assessment sometimes, either screening or a more targeted assessment, examination, intervention, and investigations as things unfold. And this is just to ensure that we really understand what this delay might be, because delays sometimes might imply that this is something temporary and it'll disappear at some stage, either on its own, with or without input. But oftentimes, if a child doesn't catch up, it then becomes a disability. So that impairment, and I like to use the word impairment as such because I think it sort of keys you into the need for us to think about this carefully and not just sort of passively think, okay, right, this child might catch up, because sometimes that impairment becomes a disability or a barrier to participation, which is what we don't want. We want to reduce as many barriers to participation in a child's life as much as we can, because those early years are so crucial and children build on those foundations. So I think one of the terms that parents may have heard too is global developmental delay, which means the same thing, really, that some of the expected skills haven't developed. It's a term, I would say, it should really be confined to children below the age of 5 years, Yang, because after that age, it's easier to tease apart the various strands of their development that we really want to key into. But under the age of 5, yes, we use global developmental delay, developmental impairment. Those are terms that we tend to use. And I think they're terms families really understand as well.
Yeah, thank you so much for clarifying that because I think one of the common questions that parents come, and as you mentioned, when you say delay, parents have a feeling that, okay, there's a delay, so there's a catch up, so everything is going to be fine. But, that term does not capture if there are significant concerns there that needs more interventions for the child And when we're talking about the development, what areas can be affected, or what areas are commonly affected, and how common are this is developmental delay?
Yes, yeah, and that's a really good question because okay, development is not static, and development doesn't just start when a child goes to school to learn. It's all the time, it's every day. It's from the minute they wake up to the minute they go to bed. Whether they're ill, whether they're not ill, they're learning all the time. So when we think about key areas of development that can be affected, we can divide it up into sort of the under twos and the over twos, or in infancy. And I think what one needs to sometimes think about is what is worrying the parent? What is that worry that that parent has that they might not be able to articulate really carefully or very clearly to you, but they've got a worry? And sometimes it takes a little bit of digging to find out what it is. I think under the age of 2 years, certainly under the age of one, a lot of what parents might say might be, my child isn't rolling. It's a lot, usually it's motor skills that parents might be concerned about in infancy, because those early skills of rolling, sitting up unsupported, crawling, pulling to stand, or bottom shuffling, and then walking unaided, really precious milestones for parents, and things that develop so quickly and so easy to see and to measure. Some things that are less easy to measure under the age of one might be things like their social interest, or how they communicate with you, because as parents, we do everything for our children, obviously. And so we preempt our children's needs. But if you think back really carefully, you'll find that children actually do request needs. They will cry if they need help. They will cry if they're wet. They might cry because they want mommy. And as they grow a little bit older, you begin to see, well, actually, when they get to about 9 months old, 10 months old, they will cry because they're with a stranger. Before that, at 6 months old, everybody's their friend. So you see different things emerging over time, but those are not as easy to see, I think, maybe as the motor skills. The other things that parent in infancy will pick up on too, sometimes it's a child who's unsettled for some reason or the other. They don't always know what it is. A child who's difficult to settle. And so there's a lot of guessing, and parents will tell you, my child didn't ever sleep. I had to take them for rides. I don't know why I had to take my child. As soon as I put them in the car and I drove up the motorway, then as soon as I got home, they were unsettled. So we treat for colic, we treat for various things. These things are common. And then it's later on in life, you think back and actually you see that pattern emerging, but in a different way. And sometimes that gives you a clue to what may have happened. The other third thing I would say, big thing in infancy, would be feeding. A child who's either breastfed or bottle fed, there might be difficulties latching on, difficulties weaning. And when you start introducing foods, then sometimes you've got really big problems with children who may have quite sensory differences, and they begin to show that sometimes at that stage. And one last thing I would say perhaps is, and this is also quite difficult to measure, is interest. Children's interest in things, reaching out, holding, exploring things. By the time a child gets to about 8, 9 months, and they're beginning to grasp and hold and shake and transfer things from one hand to the next and look for things that have fallen, call it object permanence. Sometimes if that's not there, and parents say, well, they don't really play, they don't really play. I'm finding I have to try and get them to explore things. So those are early niggles sometimes that parents have that really we shouldn't ignore.
Thank you so much for expanding on that. And I think this is, as pediatricians, sometimes you get used to the fact that you are asking for these early signs and things. I think many parents initially feel the child had been fine, they didn't recognize anything. And when you're asking them for the spot they had started noticing any problems, they might just say, oh no, it just started, becoming a problem recently. But then in retrospect, what you do find is when they become aware of some of those features, then they say to you, oh yes, he did that. And oh yes,
Yes.
he did that. And this is what we're trying to highlight is that sometimes there are these early signs, which, like you say, it's not the thing that's catching people's eyes at that time, which people may not take on board, but when they look back later, they realize that that indeed was, one of the telltale signs. And you're completely right. The number of children treated for colic,
Yes.
crying unsettled, and people thinking it's colic and just giving them colicky medicines and taking them out for these long rides and them being irritable. It's the number of children that have gone down that route. And then later on, when you picked up as they've grown older, when the developmental issues become more evident, then you put two and two together. So
Thank
in terms of statistics, what would you say? Is it something that we see commonly?
you. Yes. And I think when you're measuring again, we've with we always measure. We're always measuring things in terms of prevalence of or how common a thing is. I think most of what we know would be for children over the age of 2, a year and a half to 2 years in terms of prevalence. So, for instance, language delay as one of those things is one of the commonest things we see under the age of 2, 2.5, with a prevalence of about 1,500 children in 10,000 having an element of language delay. And what does that mean? So we say at 1 year average, 1 year, one word, single word, beginning to develop a single word vocabulary. And within that first year to between the first and second year of life, their single word vocabulary for objects, and so we'll be expanding. By the age of 2, we say 2 words together. So at 1 year, 1 word, 2 years, 2 words together. So it could be an object or 2 objects, mommy drink or daddy shoe or daddy car or something like that. And at 3 years, phrase speech, where they're beginning to put words together. So language delay is commonest, I think, in terms of measuring developmental pediatric problems. And that's without looking specifically at other things. So we know in terms of prevalence, ADHD, for instance, attention deficit, which seems to be increasing, that's 300 to 500 children out of 10,000 children. So 3 to 5%, and maybe even more, would fulfill criteria for ADHD. But that's not a diagnosis that's made under the age of 1 or under the age of 2. So we're looking at older children. So when we look at these developmental pediatric problems, we mustn't forget we've got to look at the age groups. But that term, global developmental delay, for instance, in the 0 to 5, is 100 to 300 in 10,000. So again, it's not as prevalent as what we would say language delay. And as we then look at further things like autism spectrum, which seems to be on the rise, again, maybe between 1 to 300, depending per 10,000, depending on where you are, what you're looking at, categories of diagnosis. Motor difficulties like cerebral palsy, which affects everything really in the child. That's less frequent, probably 20 to 30 per 10,000. And severe visual impairment, these are children with visual difficulties that may be from light perception only or completely blind, right down to being able to have form vision, that is, to be able to see something up close but not really know what it is. So being able to detect a shape, that's much, much less prevalent, 4 per 10,000. So we've gone from language delay at 1,500 per 10,000 to 4 per 10,000, going through, some common things that we see.
Thank you. Thank you so much. And like you said, you've talked about the vision impairment being quite low. But I think one of the things that we should flag up is that sometimes we have many children in that cohort we've just described who may have vision impairment, who may never have been picked up as well. So, and sometimes you have children having multiple conditions as part of their developmental difficulties.
Yeah.
So that's really important. So thank you, Dr. Ngozi, for that explanation and just clarity into what delayed developmental impairment means and how it can present, and also talking about some of the numbers, how prevalent, how common they are. Um, the next question that we felt we should talk about is, what are the causes? Why does one child, with pregnancy and all that could have gone well,
Mm-hmm.
why do some children develop, developmental delay or impairment when everything would have been going quite well
I
throughout
know.
the
Yeah.
pregnancy?
Yes, yes, and that's a good question. And I think sometimes we don't know what the cause is for one particular child, but I think one has to think about. I tend to divide it up into antenatal, perinatal, postnatal, environmental, and that sort of thing. And the sorts of things I think about more now than maybe 15 years ago is what actually happened before that child was conceived, even around that time, planned, unplanned pregnancy, were we living our normal life and having the odd glass of wine perhaps without actually thinking around the time of conception, where things actually start quite quickly. As we know, babies start, as we all start, as a little ball of cells, and then these cells quickly divide, and within that first 4 weeks of gestation, even before mom knows that she's pregnant, even before she's missed that period, a lot of crucial things have already started and being set down into place. We've got cells moving and dividing into brain cells, into eye cups, into spines, etc. And sometimes at those really early stages, sometimes things go wrong. It may not be drug, alcohol ingestion or anything like that. Sometimes it's exposure to toxins as well, in the environmental toxins. And that's something we're looking at in some children who are born without eyes, no eyes. So those really early stages. If it's known sometimes that there might be an infection, mom might have had an infection in utero, and we screen for things like rubella, what we call a torch screen, toxoplasmosis, CMV. These are viruses that sometimes parent or mom may not actually feel that unwell, but the fetus is affected. And then there are other things, which is why obviously we monitor parents, well, women in pregnancy, things like placental insufficiency without maybe the placenta is not performing exactly the way it should, so that baby is not getting as much oxygen and as much of those lovely nutrients. And one thing we mustn't forget too is maternal malnutrition. In some parts of the world, mothers are really depleted of their nutrients, and now you've got a baby in them who really needs those early nutrition. And then the other things we know of: maternal diabetes, hypertension, fetal factors such as multiple births. Sometimes there may be complications like that, and we mustn't forget sometimes genetic variations as well. During labor, some babies pick up infections from the birth canal. Group B strep is a common one, but nowadays, thankfully, that's something that's more easily detected than it was in the past. And then other unfortunate things like the placenta either coming apart, or the placenta being too low, so there's hemorrhage, or problems with birth, birth asphyxia, prematurity as well. And I think when we think environmental, it's really about home life, sometimes poverty, neglect. Sometimes we've got those, we take a history and there's nothing there. All of that's fine as far as we know, as far as we can tell. But there is a problem that we need to investigate. And that's where the not just the surveillance, but the screening and the assessments and the investigations start, and hopefully help to target us, to really trying to find out. So if a child is born, for instance, with something that's particularly clear, like a facial deformity, or the head size, the head might be quite large at birth, or the eyes are not properly formed, or the ears are not properly formed, or the feet or the hands might look different. That might key us into beginning to look for things like maybe a hearing defect, a problem with the hearing quite early on, if the external ear is sort of malformed and so on. But that's not always there. So the common things usually are that we don't always know, and so we do have to look. So that's really important. Again, going back to your questions about what can parents do, what should parents be looking out for, because they may not have those really clear early indicators that something might potentially be wrong.
Thank you so much for giving that extensive courses, because and I think this is what happens when we see a child whose development is not going as planned. It's almost like you're going on an investigatory process to try and understand why that child's development is delayed. So sometimes it might look a little bit tedious for parents when the doctor is asking so many questions and just exploring lots of details. I think one of the things that you mentioned, which sometimes people forget, is sometimes the stress around, during that time, or even what your body has been going through even before you fall pregnant. And sometimes women are not even aware of, the fact that they've fallen pregnant until a few months after they've missed their periods. So the whole stress and, what they've been exposed to, sometimes, stress can drive people to do things like drink or take different medications to try and just, if they're under stress. And some of those things, there are medications that can sometimes affect the child's development, which, like you've rightly said, mothers who have their own conditions, like even epilepsy, and are taking certain medications and then fall pregnant during that period, can have, like you've described, the cells that start, multiplying in that process can get affected and result in delay. And we're picking up a lot more genetic factors. I don't know whether you want to talk about that, the genetic causes of developmental delay, which,
Yes, yes. I think as pediatricians, you and I, as developmental pediatricians who worked for years seeing children where there is no diagnosis, but there's something wrong. And we can all see what's wrong. The child's not learning well. There might be poor growth, physical growth. They may not be speaking, even at an age where we expect them to be speaking. And they might sometimes look a little bit different to their family, to the siblings. But the genetic tests that we had available to us, just didn't pick it up. But within the past 10 years or so, things have rapidly changed. And what is happening now is that children who are born with perhaps similar trajectories to children who you and I would have seen 20 years ago, we're now doing specific intellectual disability panels and testing for them and picking up. There's a yield of variants of genes that are being picked up, which with more and more testing, we're beginning to see patterns and beginning to understand that, right, this gene variant, because we all have variants. You and I, we've got about 20,000 gene changes out of our 4 billion letters. All of us, that's what makes us who we are. Out of those 20,000, 10,000 can cause a disease. But it's what is that one? What is that? So it's looking at patterns over time. And with genomics now, with whole genomics testing now, we are beginning to pick up more and more, beginning to understand not just what the gene change is, but I think what the prognosis is in terms of the child's development, which does help families to plan in some ways. If you know that this genetic cause just arose in this child only, because you will test parents as well. And it was just by chance that that ball of cells had those changes, those gene changes. That's helpful for parents to know when they're planning their next child. There are some other conditions that, for instance, one that people will know quite easily, also in the Black population, like sickle cell disease, that can cause problems with a child's general health and sometimes with their development. That might be easier to pick up. But there are new ones that we're picking up all the time. So it's a very exciting field at the minute, hopefully, and I think helpful for parents. Parents are finding their support online with each other, on WhatsApp groups, on parent forums, where they actually become expert parents. And one, as a professional, one has to respect sometimes a parent's understanding of their child's profile, and we learn a lot from our children and families.
Yeah. So we do have situations where now I think you've touched on a very important area, because as many parents are coming on, or as many children are being identified with delayed development, they are picking up, they're having to undergo for genetic tests. And what I do see in the population of families that I see, obviously these tests need consent for, and sometimes many parents skeptical, and again depends on communities and cultures where they're being asked to consent for genetic tests. I've had to counsel, and but there's sometimes this suspicion about why these tests are being done, and some parents have opted not to have it done. So I think if you could just explain why to our audience, why these tests are important, because I think you've touched on it, that in the past there were many children that we knew had developmental delay, we knew that they had impairments, but we didn't know the cause, and some of those children have had further testing using the new technology that we have now, which is more advanced, and we've been able to find a cause. So I just thought it would be good to talk about this, because there might be parents undergoing this process, or who have been having double minds about why they should have this test or not.
Yes, no, that's really helpful. And I work in a genetics clinic, for children with eye conditions, and obviously the eye is linked to the rest of the body. So sometimes they are conditions that present as an eye condition, but can affect the whole child. I'll give you an example of one. It's a family of three siblings, three very healthy siblings, 8, 5, and 3, I think. And they all had a problem with being able to lift the eyelid up. We call that ptosis, and difficulty in either in moving the eye, so they'd have to turn their heads to see, because the eyes, the muscles weren't working properly. These children were bright and sparky, but the three of them had this condition, and they had no problems with their vision, and they actually had no real problems with their development as such. But in the eye clinic, we thought, well, we're going to have to try and find the cause of this. So the tests were done. Mother agreed. We did the blood tests, and we found a gene that we wasn't previously known to be associated with what we call congenital fibrosis of the external ocular muscles. That's what it's called. So the muscles that move the eyes were quite stiff, and it was a known condition, and there were some known genes that would cause it. So we looked at this and we thought, well, actually, This gene is a gene that affects the formation of tissues and sort of the building blocks of tissues. And in the cases that we do know, it affects their spines and their vertebrae. So I examined the three little ones who are very happy to be examined, looked at their spines, lovely straight spines they seem to be, but all three of them had the same condition. So we requested for them to be seen by an orthopedic person and to get the spines x-rayed and the vertebrae to see whether there was a condition. And all three of them had scoliosis, curvature of the spine that clinically was quite difficult to pick up, but the three children all had spinal curvature that was linked to this eye condition, to this gene change. So we were actually able to then write a paper to say if a child presents to the eye clinic with this eye condition, this is a gene that should be looked for because they can potentially have scoliosis that needs to be monitored as children grow. So that's one. There's also a few other ones with children who present with cataracts, for instance. And there is one very rare one, the CTX gene, that is associated with primary ovarian failure. So those children do need to be picked up and be followed up by an endocrinologist who can ensure that these children go on, the girls, if it's a girl, obviously, that they go on to develop normally. So as we're beginning to learn more and more about some of these gene changes, we can speak to parents about it. And there are some really good websites now that have been developed. As you know, I think parents appreciate knowledge. Parents can be as knowledgeable as anybody else. And it's the understanding sometimes of why we're doing these tests. So important. It's nothing to do with paternity. We're not checking to see if this is the dad or the child, but this is really all about looking at genetic counseling. If you're going to have another child, then we know what the chances are, etc., of having the same condition.
Thank you so much for for discussing this. I think this is a very important section for our audience and the reason why this genetic test are being requested and some of the additional implications that it might have on other aspects of the child's health or even the family. Sometimes it might be through the discovery of some faulty gene that
Yes.
the understanding by the geneticist, having that consultation with them, they know a lot about genes and all the problems, but they can then tell you their implications for other members of the family and who else might need to come up for screening. So there's a lot that comes on when genetic tests are being requested. So we would like families to discuss this openly, discuss your worries and concerns with the clinician, because we know that it's not sometimes an easy decision to take if you don't have all the information. And again, it might also be, our thoughts, and the clinician is there to help, simplify that process for you by helping you to understand. But just to say that there are lots of benefits from having this test done, as it might be the one answer, that helps you to understand why this has happened and if there's a likelihood of it happening again.
Yes.
So that's important. So thank you so much, Ngozi. When parents have, before they get to see the clinician or get to the doctor, what can parents do, or how can they help that process? Because some parents have said they've gone and they've been reassured, oh, there's nothing wrong. Sometimes they've gone to the GPs and the GPs have said, oh, all is fine, it's going to happen. Or especially sometimes when parents have the notion of the social aspect, they might just feel there's something off, and sometimes they've been reassured that the child is fine. How can parents is there anything parents can do to emphasize this worries? I think one thing you've said is that they should be listened to, because when parents have niggles that something is wrong, there is a likelihood that they're right, their instincts are right, being the parent of a child. What can parents do in terms of putting their worries across, seeking help?
Yes. Advocating for their child, isn't it?
Yeah,
Yes.
yeah.
That can be really difficult, I think, for many parents who, and I hear it a lot. I'm sure you do as well. Oh, I went back and I went back and I went back. And they said, oh, yes, the eyes are wobbly, for instance, but they're only 5 weeks old and they'll stop wobbling. And mom is saying, actually, no, she doesn't look at me. I think what is really helpful would be, and I say this sometimes to parents, write your concerns down, write them down and take that list with you to your doctor's appointment to say, this is what I'm worried about. Because sometimes when you go there and they're asking you all sorts of questions, things go out of your head. Go with someone as well. I think if you feel you find it hard to advocate for yourself, find a friend, husband, wife, mom, dad, somebody to go with you to your GP, to your doctor, who can help you to sometimes articulate the worry, because sometimes I think as a parent who's anxious, it may be really hard to articulate what the thing is, especially in a younger child, in a child who perhaps things are not completely clear, but things aren't right either. Here in England, we have health visitors who are specialist nurses, quite experienced nurses, who we would hope parents get to see at their child's weighing in clinics or the health clinics. These are nurses they're pediatric nurses. Speak to your health visitor. I would say, if you don't know who your health visitor is, ask your GP surgery. Because I know nowadays, rather than maybe 30 years ago, many parents say, I don't know who my health visitor is, but there should be somebody linked to you and your child after birth, after the midwife has has flown the coop at 10 days after your baby's 10 days old or whatever. There should be health visitors. But the most important thing, I think, is keep going back. If you're concerned, you must go back. Take somebody with you. Write your concerns down. Be very clear. And then if you do really get worried, in particular, if it's something like, well, my child stops breathing at night or whatever, take your child to your A&E and say, look, I'm really worried. My baby has stopped breathing in the middle of the night and I've got to shake them or whatever. And yes, they seem fine. Or my baby zones out and I can't get them back sometimes. If you don't feel you're being listened to, I would say, please persist and take somebody with you to your appointment.
Thank you so much. That's really helpful. Family should write it down. Sometimes what I say, sometimes video record movements or things
Yeah.
that you feel that you've seen, and people are not really sure of what you're describing, because sometimes it can be difficult to describe these things. And these days we're so lucky to have the cameras on our phones, and we can quickly video record the shop bait and take it to them and say, this is what
So true.
this is what I mean. I found that really helpful when parents come with videos and say, let me show you what I'm talking about, because you're sitting down there trying to get an understanding of what they're saying, but they've recorded it, and that makes such a huge difference. You say it and you can quickly know what it is, or ask them targeted questions relating to that.
Yes.
And some
That's so true.
families find it difficult to articulate what they're saying. So I like that suggestion of take someone with you to the appointment who can help you. And I've had this many times as well. Some parents are extremely anxious or emotional once they start talking about the concerns, and they get overwhelmed. And sometimes that just affects the flow of what they're saying. So having somebody to support them, I've had grandmas who are able to give a perfect history and describe what has happened, or a supportive friend who's come along with that parent who knows that child really well and can describe things. So it's so
That's so true.
important. It's so important. And like you said,
It's so
uh,
important not to be
yeah,
dismissed. Yes.
yeah, exactly. Because you've seen it, I've seen it, where this concerns from parents, and they were reassured until it became very clear to everybody. But those actions could have been taken earlier. So that's really important. So can you talk a bit about what happens? So when that child gets referred to, when the child gets referred to the pediatricians, can you just explain in a little nutshell what the pediatricians do when assessing children's development?
Okay, so you might find that they take a lot of history. They will ask you questions, but what you may find too, and I do this a lot, and I'm sure Ian, perhaps you do this too. I find it really helpful to meet the families out in the waiting area and walk back with them. This is what I do. I walk back with them to my clinic room, because sometimes in that little unstructured time that you've got with them, you actually begin to see a little bit of some of the difficulties. It could be that the child's playing in the home corner, and when they call the child, they completely ignore them. The child might not respond, for instance. So your first thing might be, did they hear? And if they did hear, why did not they not respond? So you're beginning to see those sorts of things. And then you also see a little bit about the interaction, parenthood and the child coming in together with you. And because we're assessing children, we've got to try and get them, I would say, at their best, if you can, in that short time that you've got with the families, because we know it's a snapshot of time, and we may not see everything. In fact, it's highly unlikely we see everything during the time that we've got with that family. So when a child comes to a pediatrician, they will take usually would take a history from you about your concerns. What is it that is concerning you? And then, like I said, they would probably go through pregnancy, the birth history, and a developmental history. So if you do have things either on video or you've written things down, a picture really is worth 1,000 words, like they say. Yeah, you're so right.
Yeah,
If you do have those, bring them with you. Really important, because we won't see everything. Sometimes,
yeah.
yeah, and it probably happens to you as it does to me. The little one comes in and it's their nap time. They're sleeping. Or they're just tired and they will not do anything for you. So you end up taking a history from parent, getting an understanding of what the concerns are. And if they are videos, then you can watch it. Okay, that's the movement you're concerned about. Or that's what they do when this happens. So the pediatrician will take a history and probably examine if your baby's awake. They will examine your baby or your child. And if they're able to do either screening or a developmental assessment, which might be a more formal thing, that might be done at that appointment, but it may be at a subsequent appointment. Pediatricians, quite often,
Thank,
if a child is in school or nursery, may want to get information as well from other settings apart from home to see how the child is functioning there.
thank you. Thank you so much. Now, you touched on something. The pediatrician might do a developmental assessment. And I just want you to clarify, because many parents hear the terminology, oh, my child is having a developmental assessment, developmental
Mhm.
assessment. When the child is being seen by the pediatrician for specific developmental assessment, what is happening there, so that parents, because many parents are not, they're told your child is having a developmental assessment, you don't understand what is really
Mm.
going on. They see the pediatrician playing with the child or
Yes.
just doing regular things that the child does at home, and they're wondering, is this the assessment or what are they doing? Are they just
Yes,
playing
I
with my
know.
child, or, how can they tell? So I think it would be just an
Yes.
opportunity to explain to our families what the pediatrician is doing from what
Yes.
seems like a play and things.
Yes, yes. And I think it is absolutely true. I spoke about sometimes meeting parents, sometimes meeting the child out in the waiting area. We've actually already begun our developmental assessment from there because we're looking at language, we're looking at their motor skills, we're looking at their mobility, if they're walking, um, and how that is, whether they're able, what their attention's like. They might have, whether they're getting distracted, even in those 1 minute or a short time of walking. And also, there sometimes you get an idea of even their language or their social skills in that short time. They might grab hold of your hand, or they might come up to give you a kiss. They've never met you before. So that would be a little red flag, like, okay, yes, I know I'm your pediatrician, but we've never met before, so I'm a little bit of a stranger. So you would take note of those sorts of things. And then when you go into the clinic room, if if it's yourself and the child there will probably be some toys that might already be out on a little table, which may be for the child just to sort of settle in. But even then, the assessment is continuing. We look at the way the child handles the toys. If it's a child who's walking, so let's say a 3-year-old, 3 or 4-year-old, do they show you that they know what that cup and spoon is? You might not have actually given it to the child, but do they pick it up and feeding mummy, feeding dolly already? You're beginning to see, this child is developing representational play. So children learn through play. And language, a lot of language comes through play. One of my favorite things of doing with young children is I will have some toys out on my desk on a little child's desk table in the room, but I think carefully about what I put there before the child comes in. And two things that I never put out a ball and I never put out a car, because once you've got those two, for some reason, you might have completely lost the child after that, because balls are to be thrown and cars are hard to let go of once you start playing with them. So I might put something really bland like a book, or I may put, I've got a little music box that opens and closes. And that's really just to get the child happy and settled while you're speaking to parents. And during that time, you are still assessing. Now, when you want to do something more formal, you might say to the parent, look, I'm going to do a little bit more assessment now. And it's quite hard sometimes to watch your child being assessed. All four of mine have been guinea pigs. I shouldn't say that, but they were guinea pigs at developmental assessments. Yes. And it's quite hard when you see your child is not responding and they know what a cup and a spoon are, but they're not showing that they know it. So we may start with if it's a language, or their play skills, looking at how that play is developing. And like I say, play, I talk through it as I'm doing it with children sometimes, and I will describe what I'm trying to get from that child. That play usually starts with cause and effect. So bang, 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 children mouth things for a little while as their oral exploration, but then that falls away as they begin to understand the concepts of things, maybe bricks inside boxes, they're exploring things in and out. I'll be looking at hand skills. So we look at all the different areas of development: motor skills, gross motor, they're walking, moving, climbing, etc. Their hand skills, how they use their eyes as well, their attention. We'd look at language. So even though it looks like we're playing, I might have a cup, a spoon, and a brush, and I'll say, "Oh, where's the cup? Oh, give Dolly." I might have a dolly there. Oh, get Dolly wants a drink. That's using language. Dolly wants a drink, so they may pick up Dolly and drink. You've not shown them what to do, and they give the dolly a drink. Or you might say, oh, Dolly's thirsty. Thirsty is a different word to drink. So if they've got that thirsty, okay, so the language actually is better than quite concrete language. It's so important when you're doing a formal assessment for parents not to coach the child. And so if you feel she's not doing it and you say, well, do it. Do you know? Yes, yes. This is a spoon, boys. You use a spoon for your porridge every morning. That's a different spoon that they had. What we want to see is the child's understanding of my spoon. That all spoons are spoons. All socks are socks. All shoes are shoes. So we're beginning to look at their understanding of everyday objects. So important when they're quite little. And children show you what they know. So even if they haven't got the words to say spoon, cup, whatever, they will show you by what we call it definition by use. And then even though they may do it on themselves, and then they show mummy or they try and feed mummy or brush mummy's hair, and I'm going, yes! They're beginning to extend it beyond themselves. And then from there, they might, sort of extend that to the dolly or whatever. When we're looking at their social skills, they're beginning to involve you. They're beginning to share. They're beginning to show you that and include you in their game. So we're already we've looked at motor, gross motor, we've looked at fine motor, we've looked at language, we've looked at sharing, we've looked at attention. And there may be other things that as a child grows older that we might be asking them to do. For instance, with language, you start with the objects, cup, spoon, brush, whatever, and then you might want to use prepositions or 2 or 3 things, put the cup or put the spoon in the cup. Now, that might be too easy, and that child might have already done it. So you may have to ask another question, like put the brush on the box. So you prepositions in, on, under, which sometimes are more difficult to demonstrate. You can begin to get a sense of what that child's language understanding is even before they've got words. If they're using signs, sometimes you as a parent may have to help the doctor with the signs, or you might have to interpret if English is not, or if the language is not your mother tongue.
Oh, thank you so much. I think that's been fantastic, Ngozi, because you've actually outlined what happens. That I think one of the key things you mentioned is that the pediatrician is already taking on board a lot of what the child can do, even when speaking to the parents, even before doing anything to the child. So there are times when, and it's not uncommon, quite commonly, children will come in and decide they're not going to do any of the things that you put out. They swipe all the blocks off the table and they run out of the room. They don't want to be there, or they hide under the table. All that observation, we are looking, and they are all important. So even when the child doesn't seem like he's doing things, which can be quite distressing for parents, because they might have waited for an appointment and they get there and the child is not doing any of those things, be rest assured that the pediatrician has probably captured quite a lot of what that child can do, even without them performing things. So it's not unusual. I'll just tell parents, just leave them to play with their toy if that's all they want to do. But I am watching, and all those things that you were talking about, we can sometimes get that just by watching how the child is playing, not involving their mom, not even coming to seek anybody's attention. And if that child is jumping on the couch, you can already see that the child's motor skills is quite good even before you touching the child. So there is a lot that we are already looking and taking on board before the pediatrician says that actually examines the child. So thank you so much for that. So we've talked a lot about the child's development, what delay is, and how children are assessed, and what comes out of that, and how parents can advocate for their child. So just going into the support and what parents can do, and then the intervention. What kind of interventions are there, and what can parents do, in the meantime, in terms of helping with their child with developmental difficulties? Because it can be quite frustrating for families. They really want things to happen. They want things to happen. They want things to happen quickly, many times.
Yes.
What can parents do, and what interventions are out there for children with developmental delay?
Okay, so how long is a piece of string? I think there's some difficulties that are more evident, for instance, than others. So, for instance, we talked about cerebral palsy, where the motor skills, or maybe even epilepsy, where there are those early differences that are seen quite soon, maybe within the first year of life. And the child may have already got physio and speech and language and all of that involved already. I think it's so important that we as parents try to understand what goals these our therapists, if you have got to therapy stage, and we'll talk about not getting there yet, what goals are being looked for. What are the goals? Because children, like we say, learn and develop outside of clinic rooms and learn and develop outside of the speech and language therapy department. So whatever goals and the concepts that the therapists are using, that's something that perhaps one would want to carry on at home. For instance, stretching. You can do your stretching exercises while you're putting on socks, while you're changing a nappy, um, 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 or you can adapt certain things whilst waiting for a particular therapist. For instance, if your baby isn't quite rolling yet and you feel, oh, I really want them, and they're getting stuck, then I think naturally as a parent you will help them to facilitate those sorts of movements. But I know it is difficult if you're not a therapist, B, you're a parent, C, you really need that support. I would say that whilst waiting, if your child is in a nursery, for instance, let's talk about nurseries, it's important that you speak to your nursery workers as well. What are they doing? What do they notice? What helps the child? Because we do know that sometimes children they may have meltdowns at home, but not at nursery. Why? What's the difference? What's changed? And sometimes it is that they might have access to a different type of toy or a different type of learning, and that's been tapped into there. So if a child is in a nursery setting, I would say have those conversations with the nursery workers whilst your child is there. If you are waiting for an initial assessment, then targeted intervention at that stage really would be much more difficult for you to have something to hang your hat onto. They are, this again, I would say, for the young ones in the UK, our health visitors should be there to help to tap into local services. If your child has been referred, for example, to a speech and language group, and it just looks like the child's just sitting in a group, please take them back to the next session, because they will not have one-to-one with a speech and language therapist, but that group again is helping to facilitate learning. Some parents I've found are very innovative, and I've just had to take my hat off to them when it comes to positioning children, for instance, to eat and to feed, where they might be waiting for a piece of equipment, etc. So instead of feeding the child maybe in their high chair, they may have them on their lap instead. And I think as a parent, you should go with what you know works for your child whilst you're waiting for that intervention. I would say there are some things, there are some practices I've seen that I've sort of thought, okay, I don't really think I want to feed my child, force feed a child, for instance. Perhaps that's not the right way. But guidance really is what would help. Would help what your next steps are. And there's no way around that, really.
Yeah. I think you mentioned something really important. I think the nursery, just getting more information about how your child is being supported in the nursery, what works, just paying attention to particular things that you might see that the child feels more comfortable with, or things that distress the child more. And just being positive, which leads us to, as we're rounding up, just leading us to what, obviously, it's sometimes a very difficult journey for parents. It's a difficult, if you think about, again, different communities experience this in different ways. Sometimes there's pressures of family and different beliefs that have impact on how the families go through this journey. And one of the things we always say is that these families need a lot of love and support and understanding and patience, because I think that sees them through that period. I think sometimes when people around them are not understanding, or even family members, families do feel the pressures even more, and get more worried themselves as well.
Or they feel blame, or
Yes,
guilt.
yes, guilt,
Very nice.
blame,
Mm-hmm.
stigma, isolation, is what a
Yes.
lot of the parents, experience. And this is
Yes.
speaking into
Yes.
different communities. And I just want you to touch a bit on, what, communities who are not used to this, how can they support families? What should they do?
Yes. Yeah. I am a real advocate for not being isolated. And when I say not being isolated, sometimes families have moved into a new area. They don't really know anyone within that area. I would say I can only speak for the UK. I speak for the United Kingdom. They are usually local community groups, things like what we call stay and play sessions, for instance, where parents can stay with a child in a play session. Usually these sessions, play groups, are organized by what we call our early years play leaders or early years teachers. So these stay and play sessions may include sessions of music. They might include sessions of painting or drawing or climbing or whatever. If you can, and your GP surgery should have some of this information, community information, or even websites, where are your early years, either children's centers or early years drop-in centers. Some people, we used to call it mums and tots years ago. Now it's really stay and play, because sometimes it's dads and tots or parent and tots. That sometimes is a nice place to just start, because you will meet other parents there. You will meet people, professionals who are working in the community, who can signpost to other services as well that might be helpful. So for younger ones, I would say yes, stay and play, mums and tots, play groups, really, really good, because children learn from there, from those sessions. Other, again, isolation. This is those of you who have a faith, who are linked in with either church groups or mosques or temples. That's where you will meet other people as well. You meet families, mothers. And I have to say, well, I say mothers and fathers. I have to say that parents, we're all in this for the long haul. So important to keep your health up. So important to keep Yes, the child has got those difficulties, but that child needs you, and they need you whole, and they need you happy as you can be. So if you are able to build your extended support network, friendly neighbors, whatever, I would encourage you to do so. It's important that parents continue to connect with each other. And I sometimes say to parents, when last did you guys go out on a date? When did you last, go to the movies? It's not all about therapying your child. It is, that's okay. But, we can enjoy your little one just as they are, and they will change over time. But it's really important for parents to look after themselves. And I can't stress that enough, because you're in there for the long haul. Give yourself a break as well. That would be the other thing. I would say allow people to help, allow people to babysit, allow people to mind your child. Don't feel you've got to be the perfect parent. And start every day as a new day, I would say. Make sure you give yourself a break. I can't stress that enough.
Thank you so much, Ngozi. That is just amazing. That's amazing. And just before we end up with our final bit, just to recap for our audience who've been with us on this amazing um, discussion and conversation, I've thoroughly enjoyed every single aspect of it, because we've learned a lot. We started off by talking about what we mean by developmental delay and impairment, and because you clarified that terminology of impairment, why we use that terminology as opposed to just delay. We talked about how the early signs at different stages. We talked about the red flags, things that parents may not have noticed initially, or people may look at in retrospect. We also went on and talked about the causes of developmental delay. We various causes. I think that was really good. And then we talked about the assessments and what happens during when the pediatrician is assessing your child with developmental delay, which was again really important. I think this would help a lot of parents where they don't really understand the process of why the pediatrician is coming to that conclusion, or what really are they doing when they're playing with the child. uh, Unlike other illnesses or conditions where you can do a blood test and they can tell you, yes, you've got this or that. This is a process where we are using our eyes. We're gathering a lot of information from different places. We're observing the child in different settings. We're getting input from different people. And so it sometimes can, go on for quite a while, and it's not just one contact session before we say, okay, this child is delayed. So that process can sometimes seem quite long and arduous for parents, but I think having an understanding of how the pediatrician is coming into that uh, conclusion or formulation is important. We talked about the investigations, and we spent time talking about genetic tests and why that was really important, and so that parents can have an understanding when their pediatrician says you're going to have a genetic test or we want to do this test. And we've talked about the implications or the benefits of such tests. And then we talked about intervention. We've talked about what parents can do before they actually get onto the pathway for seeing a pediatrician, and the different forms of interventions and what happens. We've touched on, what parents also need to do for themselves. And I think you talked about that so clearly, about the self-care, the importance of thinking about themselves as well. So it's been such an enriching conversation. So just to end, I just wanted to say, if you could give one message of hope or a message
Mm-hmm.
for a parent whose child has just been, diagnosed and told your child's development is, delayed or impaired? What that's a family just starting that journey. What message? What would you say to that parent?
One thing I would say is that no child is static. Children are learning all the time, and it's so important to sometimes look at the thing that the child is doing and then build on that. And I'll say this I'll give a little example. I sometimes see children who might not be able to see, or they may not be able to walk, but they can hear beautifully. And not just hear, they can discriminate between an unfamiliar voice like mine and the parent's voice. And when I see that, how do they discriminate? I talk and they might listen, but they don't do very much. And then I say, Mommy or Daddy, say something. And Mom talks or Dad talks. And you get that smile. And I say, right, what we've seen is what we call a selective response to sound. So we're going to work on that. So there are little things you can do. And how do you work on that? You must speak to your baby, speak to your child, yeah, like you do. Speak in small, short sentences. Make sure that you're using simple phrases that they can pick up on and there's repetitive. Make sure they know you're there. If your child can't see you, take their hands to your face, your mouth, your chest. So they know that voice they're hearing is that special voice and they can feel it. So what I would say is every child will show you what they can do, and you can always just tweak that a little bit more, or with that, what they've shown you, you just work within that area. If it's that smile to what you've said, hello, then the next time you might say, hello, baby. You've given them 2 words and they will respond to that. The next time you say, come on, up, 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 as you're pulling them up to sit. And as you say that, each time you see, oh, they're beginning to help you. They're beginning to brace. They're beginning to pull themselves up. When you say food time, as you're mixing their bowl of food, they might not initially know what that is, but every time you say food time and touch them up with that spoon, they begin to, oh, food time, mommy. Oh, something's happening. So I would say children always they continue to evolve and they'll continue to develop. Uh, whether they're in school, whether they're not in school, just enjoy them. I know sometimes there's a lot going on. You've got medication to give, you've got this, you've got appointments and so on. I would say take some downtime as well with them and just have fun. Just roll around on the floor with them and laugh and cuddle and just enjoy them. And the child's still learning and developing through all those little but really valuable times with you, because as a parent you're very special to your child.
Thank you. Thank you so much for that powerful message to our families. I think one statement you made there was children's development is not static. They're constantly doing one thing they have. So you continue to feed in and put into that child, because every child is special and every child has unique, skills and strengths. And I think we have to identify that strength and build on it. Thank you so much for that message of hope, which I believe every parent, no matter where their child is, would get something from that message. So thank you so
Okay.
much, Dr. Ngozi. It's been an
Yeah.
amazing session. I could go on and
Thank
on.
you.
I've just enjoyed this conversation, and I feel that our families will get so much out of this. It's about removing that barrier.
Mm,
When they're going for this process where they don't understand what's happening, they're just being told, you're going here,
mm,
you're going to get this. It can be quite
mm.
daunting for families. And I'm
Yes.
just so pleased about how you've made that so simple. And thank you so much. Thank you.
It's been a pleasure. I've enjoyed talking about it. We love what we do. But thank you for
Yes.
the opportunity, Yang.
Thank you.
Thank you.
Thank you. Thank you.